we should be seeing continuity of lactation care. Are we there? Okay.
We are, and we are recording. We're good.
Great. So most of you know me. I'm Claire Eden. I'm a board certified lactation consultant. I work out of the Georgia chapter of the American Academy of Pediatrics, which is the educational partner for the Optimizing Newborn Nutrition initiative. And today, my colleague Teresa McCullen out of Augusta will be kind of doing some follow on from last month's workshop. Are you here, Teresa? Checking that. Okay, great. Checking that I can hear you. Okay. So you may recall this slide from last month's webinar about the story of everybody, somebody, anybody, and nobody. And you may be familiar with this concept, but it goes that there was an important job to be done, and everybody was sure that somebody would do it. Anybody could have done it, but nobody did it. Somebody got angry about that because it was everybody's job. Everybody thought anybody could do it, but nobody realized that everybody wouldn't do it. And it ended up that everybody blamed somebody when nobody did what anybody could have done. And the story is kind of confusing, obviously, but the message is that, if somebody doesn't take responsibility, nothing's going to get accomplished. And the moral is that everyone participating today can do something about optimizing newborn nutrition. I really came back to this idea because I encountered a colleague of mine sent me this article that was published in 2016 in Breastfeeding Medicine about discontinuity of breastfeeding care. And I thought that was an interesting idea that we've addressed several times as we've gone through the last 2 years of this initiative. And this is a little slide from her, not little, this is a graph from her article where she has some really fascinating quotes from interviewing people at if we think back to the webinar we did last summer about how everybody has a role in supporting optimizing newborn nutrition. This graph reminded me of the everybody nobody, because it shows that like when there is a lack of resources, then we have gaps in breastfeeding care, and that means we've got inconsistent messaging and a lot of missed opportunities. And those gaps are often caused by everyone kind of thinking someone else is doing it. I should have put in that meme about all the different Spider-Mans that are like pointing at each other, if some of you have seen that. So continuity in care means that we need to invest resources to develop skills and ensure appropriate staffing. So I'm going to hand it to Teresa to kind of walk through some of that.
So thanks, Claire. Hi, everybody. I'm going to talk a little bit about how we can beef up support for families of very premature infants. And we do know that moms of these infants are more likely to initiate lactation. We talk to them about how we use their milk as medicine and how it's important. That's one of the roles that they can play in the care of their infant when they're separated from them in the way that they are when babies are in the NICU. But what we find is that many mothers are not able to meet their intended goals, even though they have initiated lactation, and some of them decided to continue breastfeeding. And some of the things that can interfere with their ability to meet their goals include pregnancy-related medical morbidities, and this can contribute to delayed lactogenesis and then impact their milk production. And I'm sure some of you that work with these families realize that it undermines the mom's confidence about her ability to even participate in the care of her infant. They're separated, these moms, from their infants for often a prolonged period of time. They are dependent on pumping to initiate and maintain their milk supply and to maintain their production, rather than being able to directly, in most cases, put their baby to the breast. And there are many competing demands on their time. They may have other children. They may eventually have to return to an outside work source, and that can impede their ability to keep up with milk removal that we know is supportive of a robust milk supply. Often visitation limitations in the NICU can can play into this also. From the AAP statement promoting human milk and breastfeeding for the very low birth weight infant, the statement multidisciplinary NICU, NICU teams can play a critical role in ongoing lactation support by providing education, institutional supports for milk provision, and medical practices that support lactation. So what would one of these teams, what do these teams look like? When you're thinking about putting together these teams, and some of you may already have these teams in place, some of the considerations include who should be there. Who are the people that should be invited to join the team and to contribute to this effort? The care team, the clinical care teams, nurse practitioners, representatives from the physician care team, bedside nurses, perhaps even mothers, the care coordinator, perhaps. I mean, you would want to give careful attention to who you have at the table to make sure that your team will function effectively. And then spending some time thinking about the goals or objective as a group, what you want to accomplish. Um, Meeting regularly and deciding how often to meet. Sometimes in the beginning you would meet more frequently than you would have to do subsequently. And then lastly, who's going to be responsible for leading the group, keeping everybody on track and making sure that you're addressing the issues that need to be addressed. So what kind of education and consultation do we need to support these groups? Um, we all know that staff lactation education is important to build confidence and competence for those that are taking care of the infants. And that includes knowledge about breastfeeding and can also help change the attitude about how we use human milk with preterm infants. Um, it's clear that readily available lactation consultants presence within the NICU with expertise dealing with um, very low birth weight infants and their families helps to make things better for everyone. And also, when the lactation consultant has experience, she can help boost the mom's confidence and offer optimum support. But in addition, the bedside nurse can play a large role in providing education and in education reinforcement because they often have more contact with the family or more consistent contact with the family than um, the lactation team. And again, I'm going to read this statement from the AAP. The NICU staff needs familiarity with the technical skills of hand expression, pumping, and stepwise progression from enteral tube to oral feeding at the breast. Family-centered care models promote family integration in medical care and improve the duration of lactation. So speaking of family education, we know that this has been shown to increase the intent for breastfeeding in families and also serves to significantly reduce maternal anxiety. So providing information for on the health benefits of mother's own milk for these infants. I have often spoken to families who are not sure, everything's going on. Their baby's in the NICU. Maybe they didn't expect the baby to be born early. And so they're not sure about their plans for feeding their infant. But getting information about the fact that their milk is used in a medicinal way for their infant often helps them feel that it's important and then gives them the impetus to get the information they need to provide the milk for their babies. Helping them understand what's involved. You want to start early and you want to frequently remove milk. And families, I think sometimes it's underestimated how much support families need to get this started and to maintain the level of milk removal that's necessary, especially when an infant is hospitalized over a long period of time. Skin to skin, understanding the almost as I might call it an essential role that skin to skin has developmentally for their infant, and it will, in addition to helping their baby develop the skills that they need to eat from the breast, to it it really can support the mom's efforts to provide milk for their infant. Non-nutritive suckling and direct breastfeeding when that's physiologically appropriate. So supporting the giving the information to staff about these issues and giving the families the information they need to participate and connect with the team care for their infant, to know when um, suckling and direct breastfeeding are appropriate for their infant. And then also, it goes without saying that they need the proper technical information about handling the milk, the safe and proper way to handle, store, and transfer the breast milk that they're providing for their infant. So lactation support can look a lot of ways, and lactation teams are used in many ways. Most hospitals fall into one of these two categories. The lactation consultant or lactation team is either a generalist or an expert. Um, when lactation teams are formed, they help everyone. They may not need to necessarily be an IBCLC. They could be someone who plays another role at other times, but is designated as the lactation supporter for a period of time. It's generally a nurse who's had some training as a lactation counselor or a breastfeeding educator and is equipped to manage the standard education and support a new mother may need. And this is ongoing support with latching her baby on, identifying an effective feed, and be able to answer any frequently asked questions. So if we look at the slide for a moment, kind of just differentiating between a lactation generalist, and someone who would be considered a lactation um, expert. And these experts are generally IBCLCs.
Yeah, so I this is a slide from that some of you may recognize from last August, when we talked about everyone having kind of a role on the team, and I just thought it was an interesting way to kind of lay out as we're going to propose that you use your multidisciplinary team to really evaluate whether you have adequate staffing, depending on what your paradigm is, and that's going to be different for different hospitals. So if we're using the generalist paradigm, what we're trying to avoid is hospitals having neither of these, right? Like we either pick a paradigm and then kind of try to go with it. In that, if you're using lactation consultants as an expert, then they need to be someone who's got the training and competency to do that. And then you need to use their time by having them be sort of like on a consult service, or by, triaging who needs expert care versus kind of that typical how to help, like, somebody who doesn't have very much lactation risk factor happening. And so those folks can be like trained to do feeding assessments. So in the NICU, that would look like feeding assessments, really creating personalized care plans, informing discharge planning. This could also apply in mother baby, right? That if you don't have very many IBCLCs, then they shouldn't be expected to necessarily see every patient. They should only see the folks that need additional or help special care. So having this also kind of lines up with like how big your lactation staff is and what their qualifications are.
So this slide kind of gives some details about things that your hospital may or may not be providing. And as Claire pointed out, it gives you an opportunity to assess whether you're using your resources well. For instance, if we think about lactation education and breastfeeding classes, who's providing that? And do you have someone that can provide that? Do you need to add someone to your staff to provide that? And Claire mentioned kind of how, if we hop down to the green section of the slide, assessments in the NICU versus assessments in the mother-baby unit, who's doing those and who is the best suited to provide that kind of care. For a community outreach, are you providing community outreach? Do you have someone who can assist with making sure that we're getting the information that the community needs to make decisions? Breast pump rental program. Clearly, moms whose babies are separated from them are in need of a breast pump and a reliable way to provide that. We often, mothers, sometimes they are surprised to have their baby born early and have to take a trip to the NICU. And so they were planning maybe to get a breast pump, but they don't have one. We need to make sure that we're providing an easy way to plug these mothers in so they can get their milk supply established.
Yeah, and this is not a comprehensive list. I'm typing in the chat. If there's slots here, we got at least two more slots. Not every hospital is gonna have all of these services, but if people are if they're part of what you're offering or what you've determined that your hospital or your unit needs, then it's important to also address whose responsibility is it to provide those things. So if you've got some suggestions on other items we should include on this slide, you can put them in the chat. Teresa, you want me to pick up here?
Oh, sorry, I put myself on mute. I'm going to finish this and then sorry, I was talking and I was on mute. I'm going to do this one and then you can pick up, Claire.
Okay.
Clinical care, again, I'm going to read the slide. By an international board certified lactation consultant, IBCLC, can improve health outcomes for mothers and babies and is associated with increased breastfeeding intensity and represents a cost-effective intervention for reducing maternal and infant morbidity and mortality. This represents a statement by NILCA on the impact of IBCLCs. The Women's Preventative Services Initiative includes the IBCLC in the same category as physicians and nurses when we are discussing clinical lactation care and services. And there is quite a comprehensive list. Again, you may be familiar with this, but it's important to kind of remind ourselves so we can have many team members to reach the goal and provide the services that we would like to provide. Licensed lactation consultants, the IBCLC, certified nurse midwives, and again, as Claire's been pointing out, all hospitals won't have all of these staff members available, but when you do, you want to think of them as being part of your lactation team. Certified nurse midwives, certified professional midwives, nurses, physician assistants, nurse practitioners, and physicians. And lactation personnel that would be providing counseling or education or peer support counselors, including breastfeeding educators and peer supporters.
Thank you, Teresa. So we've given a few paradigms around lactation services and staffing. I wanted to kind of pick up on this risk appropriate care piece because it's kind of a new, not new, it's a more recent, I've seen more references to it recently in the literature about, and really our whole like regional perinatal system is based on risk appropriate care. So using it as a strategy to improve maternal and infant health outcomes by ensuring that mothers and babies receive care by providers that are prepared to meet their needs. So some of you have seen some of this information before, but in the Surgeon General's call to action to support breastfeeding, which is getting to be an elderly statement now. I came out in 2011. It doesn't seem like it was that long ago, but the Surgeon General kind of outlined some important reasons that it's important and strategies to increase access to IBCLCs. And I wanted to come back to this guidelines that we've shared before from A1. We've shared it before, but I do regularly field requests for this information, so I thought it would be worth putting out here again. But in recognizing the importance of risk-appropriate care, the Association of Women's Health Obstetric and Neonatal Nurses, or A1, in its standards for perinatal units staffing, states that each birthing facility, all mother-baby couplets should have access to an IBCLC upon request or as a referral for more complex feeding, anatomy, and neurological impairment that affects nutritive intake at the breast. So this goes back to that. If your paradigm is that you have IBCLCs that you're just consulting for specific, more complex feeding, that means that all of your nursing staff should have support and education and competencies verification in supporting the normal course of breastfeeding. A1 also states availability of lactation consultants 7 days a week is recommended to assist with complex breastfeeding issues. We know those don't only come up Monday through Friday. And then for inpatient care, they recommend 1.3 FTEs per 1,000 well baby births and 4.3 FTEs per 1,000 babies admitted to the NICU. So you can do a little math if you know your number of births per year to kind of check where you are. I'm going to put these numbers real quick in the chat because I'm going to move on. And you could do the math while you're thinking about it. 4.3 for NICU, and that's per 1,000 births. All right. We've also got some good staffing guidelines from the United States Lactation Consultant Association. Their staffing ratios are 1 per 783 breastfeeding like well babies. So that would be 1.3 again for adjusted to 1,000, and for NICU 4.3. And then they like lay it out here, like how many FTEs for like telephone follow-up, which Laura mentioned in our chat, and outpatient appointments, and then also following up for NICU folks. And then I like that they put in, FTE requirements for providing education, program development, research. I'd like to add quality improvement on there. These guidelines are adapted from Rebecca Mannel's paper that was published in 2006. And then I think our last couple slides on staffing guidelines come from the AAP levels of care. So talking about risk appropriate care, it was all the way back almost 50 years ago, almost now, when leaders in perinatal health proposed a model system of the regionalized perinatal care for obstetric and neonatal patients. And they included the definitions of these like sort of graded levels of care. So risk appropriate care in which infants with mild to complex critical illness or physiologic immaturity are cared for in a facility with personnel and resources appropriate to their needs and condition result in improved outcomes. So the AAP publishes the levels of neonatal care statement, which was updated last year, provides a review of data supporting this tiered provision. So for level 2 or special care NICUs for lactation and breastfeeding support, they recommend that the facility have personnel with the knowledge and skills to support lactation available at all times. So that doesn't have to be 24 hours a day lactation consultants, but that there's someone in the unit with knowledge and skills to support lactation. And then they recommend having somebody on site for weekdays and then accessible by telehealth and telephone 24/7, recommending an IBCLC. This does mention certified lactation counselors. I checked with the AAP, and in addition, they didn't mean to say specifically CLC, but also other folks like some of the other trainings that are available. I know you've heard from some hospitals that have a cohort of nurses that are trained as certified breastfeeding counselors. There's other similar certifications that would be appropriate here, but they do recommend an IBCLC. And then I really like this line about operationally reviewing your personnel on an annual basis. You're going to see that again here. So for level 3 and level 4 NICUs, they recommend having an IBCLC available on site on weekdays and accessible by telehealth or telephone 24/7. And then again, reviewing IBCLC personnel on an annual basis to establish that adequately trained lactation coverage based on the specific need and volume of the neonatal population is being served. So we're going to be wrapping up here, and I have a few notes. This has come up. I've talked to folks across the state who want to hire more IBCLCs, but they're having trouble filling their positions. So I have a few points here on ensuring that your lactation position postings get a deep pool of qualified applicants and that you get increased retention of your IBCLCs or any of your lactation staff. So first is reviewing your job description and qualifications, ensuring appropriate compensation, optimizing outreach, addressing reasons for turnover, enhancing your reputation as an employer, and connecting your team to the community. And I want to have time for Morgan to present, so I'm going to go through these pretty quick, but we'll send out the slides, and I'm happy to talk to anyone about this, or we can address it in office hours next week. So first, reviewing your job descriptions and qualification requirements. Have they been updated regularly? Are they clear and accurate? Are there elements in your job description that are attractive to the applicant pool? Are there elements in your job description that might be off-putting to potential applicants? Are there requirements that may not be necessary in your job description and qualification requirements? And have you employed HR expertise in crafting your job posting to make it appealing? Looking at your compensation package and ensuring that it accounts for years of experience, any sort of specific competencies that applicants might have. For example, if they have NICU-specific expertise or training competencies, if they're good at running support groups, if they've handled pump programs, things like that in the past, that your compensation package accounts for that. Any other concurrent credentials that the applicant has. If you're expecting nights and weekends, holidays, are you including differentials? And then ensuring that there's opportunities for professional development as part of the compensation package is important. Making sure that you're working with your recruiters to optimize outreach. Some hospitals only list the positions on their career site, and it's better to also use LinkedIn or Indeed or other job platforms. Make sure that lactation services are part of any sort of large-scale recruitment events or efforts that your hospital has. And then if you're getting really desperate, are you offering referral and sign-on bonuses? I thought this was an interesting thing to think about is like if you're having a lot of turnover, that you look through reasons why people left. Are you using like exit interviews, or what are your best guesses for why you're having turnover? Like, are you offering sufficient training and orientation? Are there issues with like parking, the working hours? Could you offer more flexibility in working hours? Are your lactation staff being supervised by someone who understands their job requirements? Do you have too high of a patient load and people are burning out and that's why they are leaving? Are there unclear workflows or roles? Where does different members of your lactation team fit into the bigger picture? And then are there career advancement opportunities? And if not, is that a reason that's contributed to turnover? Taking some steps to enhance your institution's reputation in the community as an employer. This applies, a lot of these will apply to just any positions you have open on your unit, to be fair. But if there are unique benefits that your institution can offer, are they being highlighted to applicants? And are you using internal data to evaluate retention trends? Like I mentioned, the exit interviews. And then I think this is the last slide in this section, but really empowering your lactation consultants to showcase your standard of collaboration in the community. So do your lactation consultants attend or present at local professional development workshops? Do they participate in or lead breastfeeding groups or events in the larger community? And do they participate in collaborative and multidisciplinary groups within your institution, which is what we've been talking about? And I told Teresa she could do the slide because it's a fun one. Are you still here, Teresa?
I am, yes. And I actually asked Claire if I could do this do this slide because I think it appealed to me. So if you think about Glinda the Good Witch in The Wizard of Oz, she kind of glided in her bubble and she waved her wand and made everything better, everybody, all the babies were breast. So when you think about your lactation team, your lactation consultants, you don't expect them to be Glinda because they don't generally have a bubble or the magic wand. And so the concept of team approach and that everyone can contribute to making sure that lactation is established and babies are breastfeeding, and not just Glinda. Everyone can have their role with the magic wand.
Yes. A colleague of mine said this in it when we were having a venting session, and she's like, we can't just be like Glinda the Good Witch. So if you're still having trouble, and I just thought I loved the concept, so I was like, we're making a slide. So this came up in our presentation last year, but if you're having trouble filling your lactation positions, or if your nurses are overworked, I wanted to come back and throw back this idea that you can kind of grow your own IBCLCs if you integrate a role for lactation techs in your unit. And there's a few folks that are doing different versions of this, but basically you're taking that generalist idea and giving folks good supervision and training and putting them where you need more hands or more help. They could work in the milk lab. They could be a latch tech on night shift. They could be teaching about safe milk collection in the NICU. They could be doing screening. They could do some follow-up for you depending on their skill set and the level of supervision you can offer them. They're less costly than nurses. And if they're great and they feel like passionate about the work, they become board certified, you could make a role for them on the lactation team as well. So your takeaways for this section from Teresa and I before I hand it over to Morgan Shuey from Piedmont Columbus. As one, consider these potentially better practices. Of course, creating or optimizing your multidisciplinary team and make sure that you're using that team to address your infant feeding policies, practices, and quality improvement around newborn nutrition. Operationally review your lactation care paradigm and staffing needs annually to ensure adequately trained lactation coverage. And that's pretty much almost a direct quote out of that AAP statement. And then planning for ongoing and specialized professional development opportunities and competencies verification for your lactation staff in the NICU. So stay tuned. I know that's an area that there's not a lot of resources around. So that's something that we're going to be working together through this initiative this fall to develop some more resources for your teams on ensuring that the lactation staff in your NICU don't have to be Glinda and just drop down in their bubble and be expected to fix everything, but that they're more integrated and have increased competency that's NICU specific. All right, I am going to stop sharing and make it so that Morgan can pull up her slides while I introduce you. Morgan works as a clinical dietitian at Piedmont Columbus Regional Midtown Hospital in the NICU. And she collaborates with Dr. David Levine, who's one of our founders here at the Georgia Perinatal Quality Collaborative. And he was out of town and unable to co-present today, but we're really grateful for Morgan being willing to present. And here's your slides. Morgan, right now, yeah, we're seeing your whole thing. So yeah, I think that should fix it.
Can you hear me?
We were very fortunate to be able to visit Piedmont Columbus Regional Midtown Hospital this spring and on a site visit.
Can you hear me, Claire?
I can hear you, but we're still seeing your whole slide, your whole screen.
Okay. Good now?
Yeah, we're still seeing your whole screen. Can you go to slideshow and try present from the beginning and see if that works?
That's what it shows on my screen.
How about this? Like you're right now, home is highlighted. If you go over a few bits to slideshow and see if that changes it. No, up at the top, where it has like file, home, insert, draw, design. Yeah, go to slideshow and see if, try from beginning.
Also, if you have a button that says present in Teams, you could hit that. I don't know if you have that available.
I mean, this is
Are you
workable too.
Yeah, it's fine.
on 2 screens?
Oh yeah, Dr. Pena, you have suggestion?
If you're on 2 screens, you might just need to are you on 2 screens?
I'm on one screen.
Oh, okay, now. Okay.
I think we can
It'll be okay.
work from this.
Okay. Sorry.
That's all right.
It's okay. Not a problem.
Well, like Claire said, my name is Morgan Chewy. I am the clinical dietitian at Piedmont Regional in Columbus. I work very closely with Dr. Levine to do the GaPQC initiative here in our NICU. So I'm just going to go through kind of our site visit and our experience, kind of the process, and then kind of the outcomes and where we are today from the site visit itself, not necessarily just from the initiative. So this is just focused solely on what we got after the site visit. So for the team members, we were given the opportunity to take a survey from the AAP promoting human milk and breastfeeding for the very low birth weight infant. All the survey questions covered the following topics from importance of human milk, role of skin to skin, breast pump access, use of rigid containers to store milk, and use of waterless warmers to prepare feedings. Because staff lactation education increases staff knowledge about breastfeeding and changes attitudes towards the use of human milk among preterm infants. So that was before the site visit, and then during the site visit, as I'm sure most of you are aware, there is a tour, there is a staff interview with staff members, and then there is a NICU family interview. So we chose a mama who had been breastfeeding her whole time in the NICU, and she had been there for quite some time to do that interview. And she was a mom of twins. So breastfeeding the whole time with twins, we thought she would be a really good representation of our unit to tell the GaPQC staff what we are doing right and what we need improvement on. So the leadership meeting, this was personally my favorite part of it because we had a huge showing for this from leadership in all different departments, from director down to bedside nurse, and just really good conversation of kind of where we see the gaps from each perspective. So each unit's perspective of where they saw the gap was, and how it all interlocks interdepartmentally. Because like I said, our GaPQC initiative here is in the NICU, but as all of you are aware, that breastfeeding and breast milk supply go way outside the walls of the NICU. So having all of those departments present at this leadership meeting and having the GaPQC staff being that facilitator for us, and like Claire said, the cheerleader, that was inspiring. Everybody got a lot out of that meeting, and everybody was very willing to participate, which is very neat. Just so we can kind of brag about our hospital. These are kind of the accolades that they sent in our report. So of course I wanted to display those because all the staff were very proud. So the neonatologists were all present, and there was the united front that everybody in all those departments did want to improve breastfeeding, the culture, and availability to moms. So also with the accolades, they sent recommendations, very specific recommendations of what we can do as a unit to improve. I'll go back. And along with that, they sent resources. So resources for kind of what Claire was talking about with our IBCLC for our job postings, resources for community and how we can better link up post discharge from the hospital, those moms to get outside lactation support. So we went through that list. Every single member that was part of that leadership meeting, we then met again and went through all of those recommendations and resources, and were able to develop a task force. And that's an interdepartmental task force. And it kind of just rode the coattails of, after that meeting, everybody was just very excited. It was kind of, we were able to put blinders on after that meeting and focus on where the GaPQC staff made it very apparent of the little things that we could change to make a much bigger leap. So, like I said, from there, we developed the task force, interdepartmental task force. And this is who is currently on that task force. So we have women and children director, labor delivery manager, mother baby manager, NICU manager, NICU nurses, bedside mother baby nurses, IBCLC, NICU mother baby dietitian, and all the NICU neonatologists. So from my perspective and kind of what Claire just went over, I feel like this task force, from every perspective, we can get something done. And this task force was only developed because of that site visit and us being able to have clear direction from that third party. So some of the task force objectives that we've kind of achieved and set out thus far has been the hand expression with 6 hours, which is all of the goals, but kind of how we can make that interdepartment goal work a little bit better. So the IBCLC hand expression classes for nurses. We did that initially in this initiative, and we had a good participation, but I don't know about your guys' hospitals, but we have a lot of new nurses on all of those departments. So really making that hand expression class much more frequent so that new nurses, they're getting all this new information, but this is an important role in that. Benefit education handouts created for mothers. That was from our neonatologist and our IBCLC. So they work together. As I'm sure Claire remembers from our meeting, our neonatologists are very passionate about mother's milk. And we really like the terminology that they use when they speak to a mom about how she can breastfeed and provide that to her baby. So they worked with the IBCLC to create handouts for the moms. Nurse to nurse communication. This was huge. From the NICU nurse to the mother baby labor delivery nurses. So both are speaking to mom, but those nurses were not speaking to each other of how best to support the mom in that situation if they were trying to provide breast milk to the baby. Lactation consultants on antepartum. So this is a big one as well. A big increase in lactation consults, but luckily our staff is able and willing to accommodate for those. So right now we have every antepartum mom that gets a neonatologist consult, meaning that their baby will likely end up in the NICU post-delivery, is now getting a lactation consult. So before they're delivering, all the talk of our neonatologists come in and discuss the breast milk along with everything else, but now we have a lactation consult coming in and talking to them about what it looks like postpartum with a NICU baby in lactation. Pump locating and availability. Again, this is a huge thing to come out of the task force because among all the different departments, you lose pumps fairly easily. And trying to locate them, our IBCLCs were spending a lot of time trying to find out where all those breast pumps were. So having assigned designated spots, having them labeled for different floors. A few of them were in the past, but now it's a much more cohesive flow. The next one is educating, contacting community prenatal groups that exist in our local community We only know of one at this time, but contacting them and giving them the education handouts to give to moms in those OB offices so that they, again, know what it's going to look like of that immediate postpartum hand expression. What does breastfeeding look like? What are the benefits? Just getting the education out there. Women's Services nursing educator, we just hired her, not we, but the hospital just hired her. And she's going to play an integral role in getting all of the nurses up to date, up to speed, and linking them with the IBCLC, because we would like to have mandated lactation in services as part of their onboarding passport for new nurses. So any new nurses have to get their passport checked off on multiple different stations, and they want to mandate lactation as part of that. And then obviously the working towards getting a NICU specific IBCLC. We had one that unfortunately had to leave last year. Objectives, again, community opportunities, the in-hospital WIC, having WIC come into the hospital and help them fill out forms, help them show what's available to moms, and provide pumps. So we're working with that to allow WIC to come in and help moms. Providing community resources to mothers. Again, a lot of that came from the resources that they sent us post-survey of the resources. So those were very helpful. And assisting mothers with the WIC and community forms. So just, again, nurse education, bedside availability of those forms so that moms have access to those right away and can get their pumps or just know what sources they're going to have outside. So in conclusion, the site visit created an opportunity for a third-party review to help us better understand the best next step for us. Following the meeting, we are able to have a better understanding on how we can best have continuity of care among units. The site visit allowed everyone to vocalize where they needed help, troubleshooting, and how best we can better support each unit's needs. So we are taking what we have learned from past interventions and cleaning up the margins a lot more, and to have a more direct path towards our goals. And that is it.
I really like how you said that, having some clarity on a more direct path.
Yes.
Like that's very well put. Thanks, Morgan. It's giving me little warm fuzzies that you guys got something. It sounds like some good help from the site visit in terms of just like you said, moving toward a little faster or a little bit more direct path towards the goals you'd already identified.
Yeah. Yes.
Thank you so much, Morgan. That was amazing. I love getting to see all the amazing improvement work that y'all are doing. So thank you so much for presenting. If you would, go ahead and scan the QR code to record your attendance. I am going to stop recording, and if anybody has any questions, please feel free to either unmute or add them into the chat.